there like a countdown? Okay.
Good afternoon, and thank you for joining us today in this Image Live Streams challenge from Retinal Physician. My name is Marianeli Rodriguez. I'm a retinal specialist with Retinal Associates. I practice in Massachusetts. I have no financial disclosures. As you know, our plan is to post an image challenge each month and then discuss the diagnosis and management using this platform. We'd love to hear your thoughts online, and you can find us on Facebook, LinkedIn, YouTube, Instagram, or Twitter. You're also welcome to write on the chat, and you can share your thoughts with us during this event. I'm joined today by Dr. Bryan Hong. He did residency at USC, his VR fellowship at Wales, and he's also my partner at Retinal Associates. Welcome, Bryan.
Thank you so much for having me. It's an honor to speak publicly for the first time in approximately 6 years.
Well, yeah, so I want this to be a super casual discussion, and I wanted to pick your brain on what could be the most common condition that we encounter as retinal specialists in our day-to-day practice. And you and I as partners share a bunch of these patients with this diagnosis. So this 79-year-old lady presented with acute vision loss in her left eye. She had normal intraocular pressures and a unremarkable anterior segment. She's pseudophakic. Her visual acuity in the left eye was 2100. And then if we can put the image there. And this is the picture of the left eye. I didn't show the picture of the right eye, but she did have pigmentary changes in the macula and drusen in the right eye. So I just want to hear, what you think about when you see a photo like this, and then also we can switch to her OCT, and I would love to hear your thoughts on this.
Of course. You want to go back to the color fundus photo? So I've been told that the target audience is trainees at various levels, so I'll just treat this like an imaging conference. So it's a color fundus photo of the left eye. Media is clear. Optic nerve looks healthy. Vessels look normal. Retina is attached. Macula has ovoid shape mottled area. It looks kind of grayish in appearance, and there may be macular edema there based on the OCT, which is the next slide. This has, let's see, OCT showing pigment epithelial detachment below with a little bit of subretinal fluid, but it looks like a combination of macular edema and subretinal fluid there.
Yeah. When you see this in a 79-year-old lady that has pigment changes in the other eye, what is your first thought when you see something like this?
This is most likely age-related macular degeneration, but you have to think about possible polypoidal PCV. You can think about uveitis-related choroidal neovascularization or myopic degeneration, but I think based on the location and the presentation, it's probably AMD. It's like the classic appearance.
Yeah, so she's Caucasian, she's elderly. She herself didn't have a smoking history and no family history. When you see a patient like this, most likely it's AMD. Do you how often do you get FAs on a presentation like this on your practice?
I think that we used to get FAs a little bit more frequently, but when there's, I'm going to say, very little doubt as to the actual diagnosis, I think that we tend to nowadays treat more empirically. If she has clear drusen or pigmentary changes with PEDs, pigment epithelial detachments in the other eye, and just given her demographic, I'd probably go ahead with treatment right off the bat. If there's a little bit of doubt, I might try to get a 6x6 OCT angiogram, just to give myself a little bit more confidence in the diagnosis. But I don't think that an FA is necessarily required in this case.
Yeah, I agree with you. I think, I don't want to say it because we're super busy that we are getting less and less FAs, but I think our OCTs are also great. And then, a lot of times, we can see the response, a couple of weeks later. Sometimes That's something that I do. If I'm not 100%, sometimes I even do a challenge of a medication and see if that makes things better. And usually in a case like this, I would not do an FA when it's like I'm like 99.9% sure that it's wet AMD.
I can think of like a handful of cases, maybe two or three in the past 8 years where I was pretty sure it was, or almost, I was extremely sure it was wet AMD, and the response was equivocal. And in
Yeah.
those cases, I backtracked and I got an FA.
Yeah.
But I can't think, it's not a very common thing for me to get an FA after the fact. I might consider an FA if the diagnosis is really in question and I want to see the leakage or staining pattern. Yeah.
Yeah, I totally agree. And so, we're thinking this is AMD. How do you counsel this patient even um, before you offer therapy? I told you she has no smoking history and no family history.
Yeah, I mean, like, I kind of want to set the stage for expectations, and sometimes, actually, if there's no family history, I like to ask at what age their parents may have passed away, or whether their parents have any siblings, or they have any cousins who may be affected by something like this. And in a lot of cases, the patient is in their mid late 70s, early 80s, and they have a parent who died when they're in their mid 50s, and there's an entire parents' medical history is gone at that point. So I think that just letting them know, just because they don't have a known family history doesn't mean that they don't carry the genes that may have predisposed them to this diagnosis, is like kind of a way of letting them know, like, hey, I'm trying to understand where all this is coming from, and I want you to kind of understand too. And I think that just letting the patient know that their understanding is kind of key to this, because it's not just us treating them. It requires cooperation from them, their support network, to bring them to the clinic and get treated. Is a really it's just a really important dynamic to kind of fostering trust between you as a provider and the patient. I ask them, or I tell them that based on their visual acuity, the presenting visual acuity, presence of hemorrhage, or other things that may decrease their visual potential, that even once things are well controlled, or we're kind of on cruise control, they're still going to notice some asymmetric vision, that their vision will probably not return to where it was before the exudation started. So I just kind of like try to set expectations right off the bat, because I don't want them thinking that, hey, it's gonna, like, this is medicine, it's like a one-time shot, and you're going to go back to normal. And I hate when people come back the next time and say, like, hey, my vision's better, but it's not what I thought it would be. Like, I think that it's important for them to know, like, what's kind of realistic. Yeah.
Yeah, so I definitely am with you on all of those points. I always like to set the stage as well and set expectations right off the bat. And I also talk to them about one thing that I always stress to them. It's kind of like what to do moving forward to protect the other eye. I talk to them about sun protection. I talk to them about AREDS2 supplements, even though the data is not super strong, but I feel like it's the only thing that we have right now to offer. It wouldn't hurt unless we do have some patients that cannot tolerate due to GI symptoms and things like that. And I do tell them about, healthy diet. But what I do stress to them the most is actually Amsler grid. I give them one, and I always tell them to check the other eye. Even though we do OCTs on both eyes every time they come to clinic, I always tell them, if you have any other changes in the other eye, please call us right away, because, the data to support, vision preservation, the sooner you treat these patients, the better. So
it's still kind of surprising to me how people with one eye affected, if they have an appointment, 10 weeks ahead and they have symptoms for, a couple of weeks, they think it's okay to delay because they have an appointment anyways. So like, I like to tell them, hey, if there's any change, or if you suspect a change, like, call and let us know so that we can bring you in. It's better to have a false alarm in your good eye, or, the less advanced of the two eyes, than it is to have an oops moment where you have a significant decrease in vision potential.
Yeah. So I think you and I practice pretty similar when it comes to that. And our other two partners are the same. And, we have an office where people are just very open and, they just bring these patients real quick. And as you said, I feel like it's crying wolf is not really applying here. We just do an OCT, take a quick look. And if it's nothing,
Yeah.
it's nothing, patient goes away and that's it.
Exactly.
So at this time, I do want to talk about management. And we put a poll out there to our viewers, and most people agreed that that the treatment for this would be anti-VEGF therapy. And I wanted to kind of hear your thoughts in terms of choice of medication, and how long would you wait for the second to have them come back? I just kind of want to hear your thinking process when you see this kind of bread and butter presentation.
I think my knee-jerk reflex is to get any sort of anti-VEGF into their eye as soon as possible. There are certain insurances that require prior authorization or step therapy, but in my mind, when I see somebody like this, I'm like, any anti-VEGF will do from the start. And if it looks like if it looks like you can wait a little bit, unlike this patient because they had a lot of edema and the PEDs and subretinal fluid, if just the start of it, and it's only a couple of days delay, I might wait for the prior authorization. But it's Avastin is good. I've been using more aflibercept right off the bat, just because I just think that it can gain control a little bit faster. I've been warming up to Vabysmo. Sorry, I'm using the brand names instead of the trade names, but I'm just used to that. And at one point, I was really in favor of brolucizumab because it was so powerful. And then we started seeing a little bit of vasculitis and some vision loss, so we kind of err away from that nowadays. But yeah, I think any anti-VEGF to get the ball rolling is reasonable. If you have to use a sample, use a sample to get the ball rolling. But it's in the patient's best interest to try to get it controlled as soon as possible.
Yeah, no, and I totally agree. I think that here is where the art of medicine comes into play as well. We have all these trials and we can talk about them extensively, but a lot of it is also dictated by reality. And as you mentioned, their insurance, prior authorization, step therapy, things like that, and that is what's gonna dictate one way or the other. I think, as you pointed out, she's very severe. In patients that are a little bit more mild, I have, as you said, I have also a little bit more tolerance to bringing them in a week after they have PAs. In a patient like this, sometimes I would do a sample. But I will also say, okay, if you've had something like this for 3 months, probably wouldn't do a sample then. Maybe I would just wait for the PA a week later, because probably it's not going to make that much of a difference. So as you know, there's so many factors that play into that decision making. And it's almost an art when it comes to all of that. So and how long do you wait? Let's say that you gave them bevacizumab that same day. How long do you wait to bring her back?
If usually it's about 4.5, 5 weeks. There are certain constraints about like what interval between injections they'll allow. If I'm really afraid that they're, it's like a really severe case, and I'm afraid that it might cause like an RPE rupture or something, I might bring them back in the middle interval. But I haven't done that in quite some time because, unless there's like a hemorrhage or something more kind of sinister at play, I think that 4.5 to 5 week interval has worked out pretty well. There are certainly people who don't respond as well to certain of the medications, and we kind of have to juggle them around a little bit. I have a couple of patients who do require, even with the stronger medications, very frequent drug dosing, sometimes like 3 weeks. Yeah, 5 weeks.
A lot of those patients together, obviously. We cross-infect those patients, because if one of us is out, we would be treating the patient of the partners.
Yeah, exactly.
Yeah.
At
Yeah,
least.
I agree with you. Like I usually just, bring them back in 4.5 to 5 weeks. I do have one patient, for example, that I saw today. She had severe changes in the left eye, and she converted in the right eye with some hemorrhage in between the cycle, and she called me late anyway. So I'm doing Q3 weeks and I'm giving her a sample in between, but this is her good eye, and she's
Yeah.
gone through a lot with the other eye. So I just want to be at least control everything in the short period of time, and once I have that control, then I would go to 5 weeks. But as we said, it's just a lot of it is an art, and the status of the other eye plays a big role too. So that's the way I think about it.
Mm-hmm.
So so do you do, let's say that she responds really well, do you then do some when I was training, one of the things that I found so confusing about AMD is that in my VR fellowship there were like 20 attendings, and so each of them had a different way to treat AMD, and I was like, okay, what is the right way? And
Yeah.
obviously there is no right way. But I just want to hear from Dr. Hong, what do you usually do? Like, let's say somebody responds, do you treat and extend right away? Do you maintain him for a while, and then do you just jump into PRN? What is your go-to paradigm?
I think that I've been burned on enough occasions by PRN where somebody like suddenly has a recurrence and with a hemorrhage or something unfavorable that I tend to err away from PRN. So I usually maintain them at like I say on average 5 week intervals for at least the first 2 or 3 injections, just to settle everything down, make sure there's no subretinal fluid, no edema, and if I can get them to the point where it's just RPE, retina, no swelling, no exudation, maybe a couple PEDs for 2 visits in a row, I feel a little bit more comfortable maybe squeaking them out and extending them. But I pretty much do treat and extend for all my patients unless there's some reason not to. Like if people have like really big atrophy or their vision potentials are really low and it looks like they're struggling to get into the clinic because of a ride or mobility issues, I might turn them into PRN for an eye that has really poor potential. But generally speaking, I try to do treat and extend after the initial stabilization phase, and with the goal of maybe about 11 to 12 weeks max. Like we practice in Massachusetts where weather can be unpredictable, especially during the wintertime. So I don't like pushing too far beyond that because we certainly have had experience with clinic closures and road closures and things where people are delayed by 2, 3, 4 weeks at times. And, if they're already pushed out to 14, 16 plus weeks, it just feels unsafe for our patients. It'd be different, I think, if we were practicing in like California or Arizona where there's very little precipitation, but Massachusetts is a different issue. Yeah.
Yeah. So, again, for me, I think I try to extend them to 12 weeks. If I make it there and I haven't had any bumps on the road, then I'm more willing to try PRN after that. And after discussing, extensively with the patient and their family members, I usually tell them that, that would entail having more often visits for checks if we are going to be skipping injections. But some people, they say, okay, well, if we're going to be coming here every 4 weeks, that we'd rather just do it, the injection and just keep it like this every 3 months. But some people are like, I really hate these injections. I'd rather, just do it as needed. So when we get to that point, if we haven't had many bumps on the road, then I'm more willing to do PRN. But I agree with you. Building up to that point, I do treat and extend. And I tell the patients that, each eye is different, and, we see it. There's the same patient, one eye, needs it every 5 weeks, and then we can do the other one every 3 months. And I tell them that it's the amount of VEGF in your particular eye. And we can't really predict how things are going to go from the get-go.
Definitely. I think it's important, whether we choose one therapy or the other, that the patient and and or their ride or their family members or friends are aware of what's going on. Like I think that understanding just plays such an important role. And there are like a subgroup of patients who don't really care to understand, or I'm not sure they're capable of understanding certain things. But I think that when if you switch from one modality to the other, you have to like emphasize like, hey, these are the things you have to look for. Like if you're concerned, call, don't wait. Yeah, so I think that as doctors are just humans in general. When you're taking care of something that can change at a moment's notice, like there has to be some level of like understanding on the patient's part.
No, for sure. And obviously, as we had said many times, it's just very much patient dependent, and you kind of, you build that relationship with the patient over time, right? As I will say later, I've known this particular patient for 3 years. The patients that we, treat in our clinic, we kind of get to know them as much as, any other provider, because we see them so often. So I will know if this is somebody that, will tell me, if PRN will work for them. Yeah. I will know. And whether somebody just really doesn't really know at all when they should be calling me or not. And age is a factor, whether they're in long-term facilities a factor. There's so many things that play into a role, but we take all those things into consideration when we're treating one, choosing one paradigm versus the other. So tell me about your thoughts on the new meds, and how do you, let's say that you started with bevacizumab and it's not working. How many tries do you give? And then, is there a go-to med that you, if bevacizumab fails, that you go to?
My experience has been that ranibizumab is not that much longer lasting or durable than the bevacizumab. So aflibercept is a natural jump up, and a lot of insurances that require step therapy, kind of dictate some of that. I've been using why am I blanking on the name?
Faricimab?
Yeah, faricimab. Yeah, faricimab more, but I think that there were a couple of instances where the jump, I think, was too much of an extinguishing of the VEGF signal. That I've had a couple of like RPE ruptures, or things that are unfavorable. So I tend not to jump too much from bevacizumab all the way up to faricimab. Similar experiences with brolucizumab when we were using it more frequently. Not that we had like a lot of RPE ruptures, but I feel like the jump from like bevacizumab or ranibizumab up to brolucizumab. Why am I blanking? Yeah, brolucizumab versus faricimab. I feel like there's too much of a jump there, because like one is not terribly strong, and then you have these like really big guns at the top. So I think that Eylea is a reasonable step for me. Mm-hmm. I just personally feel a little bit safer kind of making those steps going up.
Yeah, so for me, I usually go from bevacizumab to aflibercept if things are not working, and then go to faricimab. Some of it, as you mentioned, is dictated by insurance. More and more are going to be requiring us to do biosimilars in the future. So we haven't really touched upon those, but that's something that will be more and more in the future as insurance dictate what we have to do. But I, in my experience from aflibercept to faricimab, there is an improvement in some patients, but I've seen, I would say like 1 out of 10, I have to go back to aflibercept because they were doing better on that.
I agree with that.
That and faricimab. So I tell them every time we're going to switch, you don't know for sure if this, don't think that this is what they're saying on TV, the 16-week is going to happen for you. Yeah. So I kind of try to lower the expectations, because in the real world is very different than obviously what the marketing says.
Yeah. Or,
So,
I mean, the clinical trials had like certain criteria for enrollment, and these were like new diagnoses and they hit them hard with the faricimab from the start.
right.
So I haven't seen the lofty, the 4 month yet. I'm still waiting on that, but I would definitely say that, going from Eylea to faricimab, generally, at least slightly more efficacious. But again, like 1 out of 10, you said you have to go back to the aflibercept.
Yeah. So for this particular patient, I'll just kind of like try to wrap it up because we've gone way
Yeah.
over time. So um, you can go to the next slide. So this particular patient, I've been treating her, as I said, for about 3 years. I started her on bevacizumab, and she had persistent subretinal fluid. So I switched her to aflibercept. So she was stable on this medication on Q for 4.5 to 5 weeks for about 5 years, and then she started accumulating fluid again at a quicker pace. So then I switched her to faricimab 9 months ago, and she's dry. I do need to inject her though every 6 to 7 weeks, but she's stable. Her vision is 20/30. She improved from 2100 to 20/30, and we've kept her there for 3 years, and she's super happy. She would love to come less often, but her vision is stable, and she's very grateful for that. So I think we've come a long way. There's lots of things we haven't touched, because we're running a little late. We didn't talk about, gene therapy and other things that may be happening in the future for wet AMD. But, hopefully more things are going to happen as we practice in the next 5 to 10 years. I'm sure that out there is going to be completely different, the way that people practice compared to today. What do you think?
I definitely agree. I think gene therapy is impressive. We're participating in a couple of things, and I'm not sure that I'm allowed to talk about some of these things,
Yeah.
but I think that definitely the duration of, or the durability of the treatment is going to continue to improve. Our knowledge about the molecular things going on inside the eye is definitely continuing to improve too. But I think that always, despite all these new things coming out, we just have to, like we started off saying, we have to set expectations correctly, because medicine for a lot of people is kind of this like magical thing, and they've never had to deal with vision loss before. So I think that they just have to know that, where the limitations are and what the therapies that we have available actually are.
Yeah, totally agree. Well, that was great, Bryan. Thank you so much for coming in. And thank you, everybody, for tuning in today. You can leave us a comment online via our multiple platforms. And we hope to see you again in about a month to discuss another interesting case.
All right. Thank you.
Yeah.